So thank you all for joining this webinar on study designs for social accountability. And in form of opening, I'll just like to make a few remarks and then introduce the presenters we have for today. First, this webinar is organized by the World Health Organization and the Human Reproduction Program in collaboration with the Implementing Best Practices Network. As many of you know, studying social accountability poses challenges at many levels. And I would just like to highlight four, which we'll be covering in various aspects in this webinar. First is the range of outcomes beyond health that are involved. And second, the processes have multiple interrelated components, steps, and actors. And moreover, the interventions change and adapt as they are rolled out due to the complex interrelationship between the community and the duty bearers. And lastly, attribution is often difficult as several outcomes jointly facilitate change. However, despite these challenges, in recent years, we have seen an increase in published studies, including some large-scale studies on this topic. And in this webinar, we will explore the applications of different methodologies, focusing on the pros and cons for randomized controlled trials design. And this will be based on looking at 3 recent randomized controlled trials. I would like to state that this webinar is a product of the research working group of the 3rd Community of Practice meeting on measuring social accountability and health outcomes. This was a meeting that was held last year here in Geneva. And for organizing this particular group, I'd really like to thank Dr. Petros Stein, Joanna Cordeiro, and Vicky Boydell, who are working with me here in WHO. And this webinar is part of a series on social accountability study designs. And then to some housekeeping issues for this webinar. The recording of the previous webinar in this series on exploring the application of realist evaluation, interrupted time series analysis, and implementation research in studying social accountability, plus this webinar will be available on the HRP website, which is shown on the slide. And if you registered, you'll also receive a link to this recording. At any time during the presentations, if you look on the right-hand side, you will see a panel at the bottom with various options. There is a tab for questions. If you click on the right-hand side of that panel, that can open up and you can type in your questions. We will take all the questions at the end of the 3 presentations, and we have organized this webinar that we will have quite sufficient time for interaction and to answer questions. We are dedicating the last 30 minutes to responding to questions. So please do write any questions you have there. Also, if you look at the panel, there's one which is marked handout. And if you click on that, you can download the handout, which includes the slides for today. And on the next slide, I apologize that I did not introduce myself before I go to the objectives of the webinar. My name is James Kiarie, and I'm working with the Human Reproduction Program hosted here in WHO Geneva, specifically with the contraception and fertility care unit. So as I said, we want to explore the application of RCT methodology in social accountability, and we look at 3 RCTs conducted in India, Ghana, Malawi, Sierra Leone, Tanzania, and Uganda, and also look at the pros and cons of RCT design when applied to social accountability. And today we have 3 excellent presenters, and Our first presenter, on the next slide, our first presenter, Angela Bailey, is the Managing Director, Accountability Research Center at the American University, and identifies as an international development practitioner with expertise in applying best practices to research design and implementation. So it's really a pleasure to hear from her, and over to you, Angela.
Good morning, everyone, or afternoon. It's 6 a.m. where I am in California, so hopefully you can hear me. I currently work at the Accountability Research Center, and it's an action research incubator based at American University. And our founder, Professor Jonathan Fox, has a long history of research on and studying accountability. So today I'm going to talk about findings from 2 randomized control trials on health accountability in Uganda. And hopefully this is just a conversation starter. So why am I presenting on these 2 RCTs? The main reason is from 2004 to 2016, I worked for the Irish NGO GOAL based in Uganda. And GOAL led the implementation of the Accountability Can Transform Health program, which was the subject of one of the RCTs. So I didn't do the research design or data collection or even the analysis and writing up the findings, but the perspective I bring is more of a strategist and an implementer of the intervention at that really important nexus of health and governance. So next, please. So the first RCT, Power to the People, was published in 2009 based on fieldwork in 2004 and 2005. It reported very strong positive findings on health, and it popularized a relatively simple and inexpensive accountability approach. So because it popularized an approach, the purpose of the Act Health RCT was to see if those strong positive findings could be replicated 10 years later. So both of these RCTs tested 2 key elements of a specific approach. One was providing information to community members and health workers, and the second was facilitating dialogues between health workers and community members. And because the Act Health RCT was a replication of the prior work, the implementation had to be as similar as possible to Power to the People. So both interventions disseminated information in the form of citizen report cards based on household and health facility surveys. Both facilitated those dialogues, and each dialogue culminated in an action plan. And during follow-up dialogues every 6 months, participants reported on progress against those action plans. Those are the basics. There were some differences, mostly because the world of RCTs had changed considerably between 2004 and 2014. And the Act Health is a more robust RCT for one key reason, and that's the sample size. So Power to the People had only 25 treatment health facilities, and Act Health had 281. So I wanted to, if you can see in the slide, hopefully those links work. I mean, both of those papers are very, very available, and I encourage everybody to read them as well. Next, please. I did want to mention that the Act Health program did have a multi-level strategy that was implemented after the randomized control trial. So because the Act Health RCT was designed to retest that relatively simple theory of change, right, about sharing information and facilitating dialogues in health facilities, it's kind of a light touch approach. And this is the type of short causal chain that can be studied with a randomized control trial. But just because it can be studied with the RCT doesn't mean it's comprehensive enough to really promote the kinds of changes we're hoping for. And James mentioned some of those different complexities that are related to accountability programs. There's a lot of actors, a lot of stakeholders, a lot of things are involved in more substantive change. So because the theory around programming and practice had evolved considerably, we had a larger program strategy we were able to implement, even though the RCT only tested part of it. So that's what that little diagram there shows, is kind of the initial activities, which were the community-based activities that were studied in the randomized control trial. But there were a couple of other major elements that were not included. So we're actually writing a paper on this, and it's of interest because the support to these people's advocacy campaigns and bringing people together from multiple health facilities was really important to the theory and to the practice, but it was much less amenable to being studied in a randomized control trial. Next, please. So let's compare some of the key impacts recorded. So some of you might already know the punchline if you're familiar with either of these studies, that Power to the People reported very strong results on health outcomes and Act Health did not. So Power to the People reported a huge impact, a 33% reduction in under 5 mortality. But because of the sample size, well, partly because of the sample size, that's not a statistically significant finding. And the actual range is probably more is actually in a much wider range of figures, maybe between 8 and 64%. The Act Health RCT found no impact on health outcomes like facility use, weight for height, or child mortality. Under service delivery, Power to the People found intervention facilities may be more likely to have suggestion boxes and waiting cards. And Act Health RCT found modest improvements in patient satisfaction and treatment quality. In the area of community monitoring, the Power to the People researchers said that community-based organizations that implemented this reported that community or health members also were monitoring health workers when they visited the clinics. In contrast, the Act Health RCT found little evidence that the intervention caused citizens to monitor more in the health centers. And the final area is the relationship between top-down monitoring and community-level efforts. So the Power to the People researchers speculated that it could be a combination, actually, of bottom-up monitoring with top-down monitoring that could yield even better results than those that they found. In contrast, the Act Health RCT, well, actually, and likewise, the Act Health RCT noted that top-down monitoring might be more powerful than bottom-up monitoring. So I haven't done these justice, but the time is short. So I wanted to look, if you go to the next slide, please, at just one indicator of community monitoring. So it's important to look at this given how important community monitoring is to the overall theory and how sometimes it's not fully defined in social accountability approaches. And these are indicators. Most indicators, especially in governance and accountability work, are proxies. This is one of the measurement challenges. And the challenge of getting great indicators is not unique to RCTs, and it's something we're looking at at Accountability Research Center. So if you see Power to the People, the kinds of indicators they were assessing of community monitoring are suggestion boxes, waiting cards, posters about services and patient rights, and whether or not health facility issues were discussed in local political meetings, so local council meetings. Now, of these, really only number 5 could arguably indicate community monitoring, and the rest, from my perspective, would be more about transparency or behavior change or information dissemination. Those are not necessarily equivalent to community monitoring. The Act Health RCT 10 years later operationalized community monitoring in a slightly different way. And I won't read those because you can see them on your screen, but I will point out that, so of the 4, the second one, whether household members who attended the LC1 meeting, the local meeting, report that health center was discussed, is probably the closest to community monitoring. But if you see the rest, they're really based on a series of kind of very indirect hypothetical situations or scenarios. For example, number 4, whether household members think engaged community members would find out if a health worker did not report for work. So in some ways, there's an implicit assumption in both of these pieces of research that the intervention is a big part of the actual monitoring that community members do. And in a more sort of nuanced theory of change, you would hope that this intervention actually triggers more independent monitoring. Yet what happens outside of those induced activities is much more challenging to know. For example, in the ACT Health program, we could not have contact with the intervention communities in the 6 months between dialogues. So we don't fully know what happened in between. And the bottom line is that the ACT Health RCT authors found there was no evidence of community monitoring, but that finding is based on this indicator construction. And then they kind of more broadly conclude in their paper that there's a weakness of bottom-up accountability. It's a bit of a broad conclusion to make given what they actually measured. Next, please. So this kind of exercise calls on us to check on the fine print in all kinds of research studies, not just RCTs. And there's some key questions that's important to ask. You know, what drives the research, and does the data support the conclusions? So Power to the People was a very early field experiment in health accountability. It was sort of light touch based on just information and dialogues, and it sort of set the tone for the field. It got a lot of people really excited that you could have very short, inexpensive ways to trigger more citizen engagement and accountability. The ACT Health RCT was basically driven by a desire to retest that earlier theory. And unfortunately, it did not include newer theories and approaches that are much harder to randomize and to measure. So organizing people across geographic areas or between communities, that's sort of a horizontal organizing, approaches that really specifically address and tackle shortcomings in the whole chain. So looking at higher level officials beyond the health service providers who might not be able to solve everything on their own. And then also that relationship between top-down pressure, which wasn't really tested in either of these randomized control trials, even though both speculated that that was important. So on the one hand, on Power to the People, it's statistically underpowered, which should cast doubt on some findings. And then the ACT Health RCT has a headline conclusion about the weakness of bottom-up monitoring, but that's kind of based on a weak proxy indicator. So if the last 15 years were based on a lot of hope that small investments and sort of simple short interventions could make dramatic changes, that enthusiasm is understandable. We all want to see things change, and we want to see things change for the better and quickly. But it's probably not very realistic because there's no accountability on the cheap. It's complex and relational, and it really requires a lot of time. But these mixed findings from RCTs provide us an opportunity to discuss the tougher questions at the intersection between health governance or health and governance. So with RCTs, we can study these light touch, relatively simple interventions, but it's not clear what we can really learn from this kind of research. So what's the appetite for implementing and funding health accountability work that actually maybe doesn't demonstrate quick causal impacts on high-level health outcomes like morbidity and mortality? And how do we really marry support to complex change strategies with robust research for two purposes, right? One, to promote positive change, and then second, to gain more insights about how that change happened. So I know maybe people joined this webinar hoping for a break from COVID, but COVID pandemic is actually just reminding us and resurfacing all of the persistent weaknesses and challenges in health systems around the world. And it poses these dilemmas because vaccines and other technical health interventions might be necessary, but insufficient to advance health outcomes. So just to close, I'd like to use the words of somebody who wrote about this much more eloquently than I, Thomas Bulke, in Plagues and Paradox of Progress, that the last 2 decades have brought dramatic reductions in endemic infectious disease and child mortality, but not the improvements in healthcare systems, responsive governance, and employment that accompanied those changes in wealthier nations in the past. So unfortunately, I think RCTs are unlikely to answer what works type questions because the types of complex change that we're talking about involve pathways that are difficult to study with RCTs. And that's it.
Yeah, thank you very much, Angela, for that excellent presentations. And please, if you have any questions, post them on the question chat box, and we'll be able to answer them at the end. So our second presenter is Harsha Thirumurthy. Is an economist and associate professor in the Department of Medical Ethics and Health Policy at the University of Pennsylvania. He is also associate director of the Center for Health Incentives and Behavioral Economics at the same university. Dr. Thirumurthy's interests lie in studying the intersection of economics and public health. And welcome, Harsha. Over to you for your presentation.
Thank you so much. It's really a delight to be here and be part of this webinar, and hello, everyone. So this presentation from me is going to report results from a study we just completed in India, and it builds very nicely on the excellent summary of the work from Uganda by Angela, and hopefully will add to the to the things we could discuss about accountability interventions in the health sector specifically. So the study I'm reporting on was done in partnership with several individuals and organizations. I want to acknowledge at the outset my collaborators on this project, Manoj Mohanan at Duke University, Vikram Rajan from the World Bank, and Kendall Swanson also from Duke University. So just to give you a little bit of context, the project overall was very much motivated by some of the seminal work that Angela summarized from Uganda, which early on at least demonstrated the promise of accountability interventions. And what we were really motivated by in this question, in this project, were two large questions. One is context. So it's great to know that in Uganda, an intervention succeeded at least early on. But what about a different part of the world? How does that work? So that's one question. The other is about scale. And so it's one thing for researchers to implement an intervention and have a lot of hands on and control over what happens, but it's another thing when the state is implementing these interventions, and so we're really interested in exploring what this looks like at scale. So with that context in mind, I want to tell you about the social accountability interventions that were implemented here. This is in the state of Uttar Pradesh in India. As many of you may know, it's the largest state in India with a population of over 200 million individuals. And it's also is the state that has among the poorest health indicators in India when you look at everything from nutrition outcomes to infant and maternal mortality rates. So this social accountability intervention was part and parcel of a larger project that was supported by the World Bank and run by the government of UP or Uttar Pradesh. This was the UP Health System Strengthening Project, and the goal of the project was to improve health service delivery as well as health outcomes at the village level in rural UP. And the idea was to increase engagement with community members as well as existing community-based organizations. The project did a number of different things, but we're going to focus here specifically on the social accountability component of the project. In that component, the goal was to strengthen the functioning of existing committees that promote health, sanitation, and nutrition in villages, and to improve the performance of the frontline health providers in India, in UP specifically. And so the premise here was that one of the reasons why health outcomes are so poor in UP is that the quality of health service delivery is not great, and provider effort may be lacking. And so could the state, through the use of social accountability, bring about positive changes here? So the next slide tells you a little bit more about how social accountability was implemented in Uttar Pradesh. Importantly, it's worth pointing out that the state appointed an existing state level agency called the Institute for Rural Development to implement this program in 12 districts across the state. So the goal here was to reach a very large number of individuals through social accountability, the State Institute for Rural Development essentially developed a suite of information and training materials that would be used in these 12 districts. Our study, which I'll tell you about on the next slide, will focus on 2 of those districts specifically, but I just want you to appreciate at the outset the fact that this implementation of social accountability was really run by the state, and it used existing agencies within the state to roll it out. So what the State Institute for Rural Development did is it recruited over 300 Gram Panchayat coordinators, or so essentially village level individuals whose job was to go to villages and to activate these village health, sanitation, and nutrition committees that were comprised of elected members from a local village, like the village leader, as well as health workers. All villages in India are supposed to have a VHSNC, but what the state government recognizes that in many villages, these committees were not operational. So at the outset, the State Institute for Rural Development sought to activate these committees and to form them and start convening them. So SIRD essentially recruited and trained these Gram Panchayat coordinators, and those Gram Panchayat coordinators in turn trained over 10,000 village health and VHSNC members across all of those 12 districts. So essentially they started going to villages over time and reaching out to the leaders within those villages and started to form these committees. So on the next slide, I'm going to tell you specifically about the RCT that we conducted. What we wanted to do is look at the effects of the social accountability interventions on health outcomes as well as health service delivery when they're implemented at scale in a resource limited setting like UP. We wanted to look also, building again on some of the findings from the studies in Uganda, we wanted to look at specifically what happens when you just provide information to community members versus not just providing information, but also actively facilitating the interactions between citizens and providers. So in this RCT, we're specifically trying to disentangle whether this extremely light touch approach of giving information to community members is sufficient for bringing about better outcomes, or if instead you need to also increase the facilitation and manage that process. So in this study, we worked with the state government very closely from the outset, and we selected 2 of those 12 districts where the study would take place. In those 2 districts, there were 120 Gram Panchayats, which is in India, it's essentially a collection of 2 to 3 villages. So these 120 Gram Panchayats were randomly sampled in those 2 districts, and they were matched into trios based on population, on baseline health outcomes. And they were then randomized into 3 different groups. One group was a control group where there were no additional interventions taking place. In another group, there was only information that was provided to households in those villages, in those Gram Panchayats. And it was the Gram Panchayat coordinators that were state-appointed officials who provided that information. And this was information that essentially informed people about baseline health indicators, as well as what health services they were entitled to, what were the roles and responsibilities of various health workers within the villages, as well as the village health, the committee with the VHSNC. People were also informed that there is a discretionary fund that's available for the village, and therefore they were informed that that fund is supposed to be used to promote health and other development indicators in those villages. In addition, the third arm, what happened is that it was information was provided, but in addition, the Gram Panchayat coordinators made extra efforts to activate these VHS&Cs and assist them in organizing monthly meetings. So the idea was to take some steps to ensure that these meetings were happening on a monthly basis, to inform community members that these meetings were coming up, and the goal here was to move that process of VHS&Cs meeting regularly further along. Then, and so as part of the research design, what we did is we had a baseline survey that was conducted in these 120 villages with a sample of households, and then a follow-up survey that occurred about 24 months after the baseline survey. So in the next slide, I'm going to just summarize the results that we found, and I should just say that again, what I've neglected to do here is include a link to the working paper that reports these results. So the study is currently being peer reviewed, but there's a working paper that's available, and we can share that. It would be available through a website at Duke University. So 4,800 households were participated in a follow-up survey that was completed after about 24 months, and essentially what happened is you had at least 12 months of the social accountability interventions that had taken place in these villages, in the intervention villages specifically. In the 3 arms, so you had 40 villages per arm as a reminder, and the baseline characteristics were very similar across these arms, and that was by design. This figure essentially reports to you the effect sizes that we found for a number of different health and health service delivery outcomes. Just one thing to say about this is the figure is presented in such a way that if you see an effect size that's to the right of 0, that means that it's having a positive or favorable effect, whereas if it's to the left of the 0, if it's negative, then it's having a negative effect on the outcome. So when you look at reduction in stunting, for example, we wanted to present this so that a move to the right is seen as a favorable change. So there's a stunting prevalence is going down. So what we see overall, the headline results here are that both interventions, the information provision as well as the information and the facilitation of these monthly meetings, led to less stunting and wasting among children below 5 years of age. There was also an increase in full immunization rates, an increase in facility-based deliveries, as well as a reduction in fertility. A couple of things about those outcomes. What you can see is that for nutrition, stunting and wasting indicators, the information and the information plus facilitation interventions both had very similar effect sizes. So there was not the case that the facilitation added to the effect of the intervention. For full immunization, we do see a stronger effect for the information plus facilitation. And in terms of whether the magnitude of these effect sizes, at least for stunting, there's about a 3 to 4 percentage point reduction, which you can see in this figure. And that's just to keep in mind, that's relative to a mean of about 50% in the control group. So you're seeing a 4% reduction in stunting, 4 percentage point reduction in stunting off a mean of 50%. So it's a sizable reduction. Same thing with full immunization in the information plus facilitation arm. There's a 13 percentage point increase in the likelihood that children between 12 to 23 months are fully immunized. Where we don't see effects of this intervention are in treatment, rapid treatment for diarrhea, which again is one of the important causes of both malnutrition and mortality. We also see no effect on child mortality in the study. As Angela pointed out, in the Uganda study, at least the first one, there was a very large effect seen on mortality, and here we don't see any such evidence of a reduction. And as I said, there's some modest evidence that the information facilitation is more effective than information provision alone. Surprisingly, when we asked participants about their satisfaction with the frontline health providers, the people that we think of as being the primary individuals in charge of delivering these services, the ASHAs, the auxiliary nurse midwives, the Anganwadi workers who are there to deliver in nutrition and childcare. There's actually a worsening of outcomes. Generally, this is not statistically significant, but in some cases, there is a significant reduction in satisfaction. So that was a surprising finding here. So just to conclude, and I certainly look forward to the discussion at the end, the information provision alone, as well as the combination of information and facilitated community meetings, did lead to some notable improvements in child health outcomes and healthcare seeking behavior. Some modest evidence, as I said, that combining the provision with facilitated community meetings may lead to larger effects on health outcomes. And we think what's important here is that this RCT, I think one of the attributes that we want to emphasize is that it's really important to be testing things at scale, and by working with the state government here, we were able to hopefully generate results that would be more generalizable in terms of what would happen if a state in India were to implement these interventions at scale. At the same time, there were some surprising findings when it comes to satisfaction with healthcare providers. And when you look further up above the village level, that's an area where we did not have sufficient data in terms of the top-down monitoring. And that's something I'd love to discuss in the Q&A. Just to conclude then, I'd like to acknowledge the various partners in this work, including the World Bank and the government of Uttar Pradesh.
Thank you very much, Harsha. That's an excellent presentation, and there are some questions, and we'll come back to them after the next presentation. So the third presenter is Courtney Tolmie, is the Senior Program Director and Lead for Results for Development Accountability and Citizen Engagement Practice. She also works in research as the Principal Investigator for the Transparency for Development Program. So Courtney, over to you.
Great. Thank you, James. And thank you to the organizers for putting this together, and to Angela and Harsha for, I think, wonderful presentations about both the opportunities that RCTs hold for social accountability, understanding social accountability for health, but also some of the challenges. And I think this presentation, which focuses on the Transparency for Development project, which I'll share a little bit more about, similarly highlight both some of those opportunities and those challenges. This project was led in collaboration with the Harvard Kennedy School and Results for Development, which is a nonprofit that I work with. And we worked and benefited from many, many amazing local partners, including CSOs and research partners in 5 countries, and I'll talk a little bit about those. So if we move on to the next slide, when we originally designed the Transparency for Development project, this was really designed to surface evidence not only of whether transparency, accountability, and participation can improve health outcomes, and in our case, maternal and newborn health outcomes, but also to really try to open up that black box and understand questions of how and why and through what mechanisms and in what context. And, this really stems, like a lot of work in this field, from, the first Uganda study that Angela talked about at the beginning of this webinar, where there's such promise, I think, back in 2004 and through 2009, of what these types of social accountability programs might be able to do for health. And then in the subsequent years, a lot of kind of questions as we saw more and more studies being done, and really some challenges in replicating those results. So what we decided to do with the Transparency for Development project was implement this pretty unique mixed method and multi-country impact evaluation, We worked in 5 different countries over 2 phases. The RCT component of our work really took place in 2 countries, Tanzania and Indonesia. And so I'll start by focusing on those. But from there, I actually really want to broaden this out to look at the benefits that you can get from a mixed methods approach, both within those 2 countries, but also in the countries we worked in phase 2, which were Ghana, Malawi, and Sierra Leone. This work started in 2013 and continued through 2019. And I think the timing of this is quite interesting because when you look at the social accountability field, when we were starting this work in earnest around the beginning of 2014, we were at this interesting kind of inflection point for accountability where a lot of us, myself included, that have worked in social accountability for many years, were looking at the types of light touch interventions that were tested in the Power to the People study, and having some real questions about whether that was the direction that the field should continue to be going in. But at the same time, working with a lot of local partners who were continuously hearing from development partners saying, what we want to do is bring in a community scorecard or bring in a light touch approach to accountability. So what we tried to do with our phase 1 work with the Transparency for Development project was to take that kind of light touch community scorecard, to work with local civil society partners who've been doing this for many years, and to try to make some adaptations to kind of make a final, maybe not a final test, but a test of whether or not an adapted, still fairly light touch approach to a community scorecard could lead to changes in health outcomes. So what we did with our partners is we adapted this community scorecard approach in 2 major ways. First of all, we opened up or reduced the constraint on the types of health problems that the scorecard could focus on. So one hypothesis is that a traditional accountability intervention focuses on very specific types of health problems, leakages of funds, absenteeism, things like that. And what we wanted to do was to say, maybe different communities are facing different health challenges. So let's really leave it up to people to see what they want to focus on. And then the second adaptation we made was actually opening up the types of social actions, whether those be social accountability actions or other actions that communities chose to undertake as a result of kind of information and facilitated discussion of those problems. So moving to the next slide, our research question for the RCT component of this work was, what is the impact of this intervention on 4 major things: utilization of healthcare services, content of healthcare services, so various measures of quality, maternal and newborn health outcomes, and citizens' perceptions of empowerment and efficacy. I'm happy to share the link to our full RCT paper, which is under peer review, but is available online in working paper form. But the big picture is that in both Tanzania and Indonesia, we ended up seeing no impact on average of any of our outcomes of interest. Interestingly, and I think this is something that a number of my fellow researchers and I are starting to look at more, we did see increases in many of the health outcomes across both treatment and control communities in both countries. So I think it's an interesting thing to look at in terms of whether or not accountability could potentially have a larger impact, if there's not other big changes happening, and I think big improvements happening in the health system and some of those outcomes. But this at this point is just a hypothesis. I think it's a footnote worth looking at. So then moving to the next slide. So what do you do if you have an RCT that doesn't give you any results in terms of impact? And I think this is one of the really unique things about the T4D study, and one of the things that we built in from the beginning was that, we didn't just want to understand, did this work, yes or no, but also to be able to provide additional evidence about how and why. And that was really why we built this in a mixed method way. So a few other questions that we were really able to answer as we went along. And actually, Nandita, if you want to just present all of the, go through the animation here to save some time. So one of the things we looked at here was, did people participate in design actions? So this is a potential breakdown we could have seen. And we saw across the board that yes, and the actions that were designed and undertaken were quite diverse with some important trends. We looked at whether or not participants had a positive experience with the program and just in general how they experienced it. And what we found was that despite the fact that we saw no changes in overall empowerment, for the citizens that were really engaged in the program, even several years later when we did our N-line, we found that it was actually very empowering in Indonesia. It was more neutral in Tanzania, although slightly empowering, and that the experiences of people were actually quite complex, which is something we can, I think, learn a lot more from in terms of the experience of citizens in accountability efforts. We looked at where the intervention broke down, which I think is one of the most useful and practical things for organizations that are doing this type of work. What we saw was that actions happened, they were completed, but they weren't enough to have an effect on intermediate outcomes, which led us to then ask, well, why did the intervention not lead to intermediate outcomes? And we have several hypotheses related to this, which we're also writing up. We think there's a lot of things related to the intervention design factors, context factors, response, this issue of history and memory, which we were able to look at through this ethnography that we embedded into the approach. And then finally, and this is actually where I'll end, we also wanted to understand whether there were design approaches to social accountability that could work better. And this is where our phase 2 comes in. So recognizing some of the trends from phase 1, one of the things that we observed was that even for some of the problems that communities wanted to address that would require engagement and action with government officials above the kind of local level, we didn't see actions that targeted that level. And so what we tried to do in phase 2 was design an approach that actually brought in a subnational government champion or set of subnational government champions that engaged with communities in a very collaborative format to address some of these bigger health issues. Now, on the positive side of this, we saw that in 2 of the 3 countries where we worked, we have very, very positive results. We actually saw many more actions going up to the government level at the subnational and even in some cases national level. We saw real evidence that several of those actions were connected with changes in the outcomes that communities wanted to see. And so I think this is really promising. I think the trade-off here, and this gets back to a point that Angela raised earlier, is that a lot of those types of interventions, including the one that we studied in phase 2, are really not amenable to randomized control trials. They're not easily randomizable. They have to happen in a large enough space that getting the kind of power that you would need to do an RCT becomes really challenging. So on the one hand, we see these really positive results from phase 2. On the other hand, they're not RCT results. They are rigorous, but at the same time, there are questions about how much we can draw, when we don't have a control comparison to those. So maybe I'll end it with the last slide. So just in conclusion, I think what I would suggest, and this is probably not a surprise to anyone, is that RCTs are quite important, but I think especially in the direction where social accountability is going right now, the RCT alone is not going to be enough to tell us about what's going on and may not be the right tool always to study the type of accountability that we're increasingly seeing. It has the potential to be more effective. What we saw with our work was that the other methods that we were able to build in, both in phase 1 and phase 2, told us a lot more about the big picture. And I think in discussions with CSO partners, both the ones we worked with in this project and others that we work with, a lot of the findings from this kind of mixed methods approach are the ones that they've been able to really take and they say strengthen their work with. So I think I'll end it there. I will share some links to some of our papers. I realize I didn't include those in the PowerPoint, but I'll share them with the organizers to hopefully share beyond. Thank you.
Thank you very much, Courtney, for that very nice presentation. There are a number of questions and we'll be coming to those. I think we are just about 10 minutes off from time. So I'll ask the presenters, though there are quite a number of questions, just to take 3 minutes and and highlight the key responses. I'll start off with Angela. There are two questions. So one, if RCTs will not answer the question, then what can be used in the interim? And the second question is, how can learnings from your RCT or from the RCTs be applicable to other parts of the globe? Over to you, Angela.
Thank you. Those are both great questions. I think that some of the examples that Courtney provided about the observations from the process monitoring and from the ethnographic work that they were doing in coordination with the RCT, many of these programs have process monitoring information or other data sources that can be used to offer more insights and more nuance. So I think that's the first thing, is looking at programs that have been implemented and where there is additional information. And even as Courtney said, even if they're not RCT results, they can still be robust and we can still really learn quite a lot from them. In terms of the question about transferring to other contexts, that is much more challenging, and that's one of the big challenges that people find when they're interpreting RCTs. So RCTs are really well-designed. RCTs are good for just confirming that the effects detected were truly measured from the program itself in the context in which it was implemented. So these kinds of other observations about context and the kinds of things that are likely to make change where you are, we can learn about a lot of things from theory and from what other people have done, but that's just part of what goes into thinking about a program design or a research design. So yes, there's looking at past research findings, but also really doing a deep analysis of the context where you want to try to do some kind of work around accountability. So there's never going to be, well, one of the challenges with the what works question is it implies there is an answer and that something will work in many places. What you might find is that variations of something might work or could be tried in different places, but you can never, I don't think, and maybe Harsha or Courtney would have a different idea about this. I think it's very unlikely that you're going to be able to copy and paste an intervention from one place to another place and get the same results.
Okay, thank you. Thank you very much, Angela, for those responses. And just the questions will also be sent to the presenters so that if there's opportunity or questions that have not been answered, then there will be an opportunity to respond. So Harsha, there are quite a number of questions. One of the first questions is, what are the indicators that you used in discussing with the Ashers and the other health workers that were in the negative? And you should kind of, the second question is, you showed kind of relative changes, but what was the magnitude of these changes? How big were they? And the third question is just a request for more information on the study, the nature of the facilitation, the duration, the costs, and why, for example, some of the interventions that are expected to be initiated in the household, like time for diarrhea, time to initiating diarrhea treatment, were not affected. And then the last question is that the study seems to look more at changed consumer behavior. Do you think it really informs the issue of accountability? And finally, has there been buy-in of these results by the state? Is there now a plan to scale up this intervention to the whole state? Over to you, Harsha.
Great, thanks. That's a number of good questions, and I realize some of them are more of the detail-oriented. So just a few things in response. One, the indicators for the ASHAs. So we collected longitudinally from community members, essentially their overall two things. One is like the awareness of the roles and responsibilities of each of those healthcare providers, and so that certainly improved. But in terms of satisfaction, it was essentially a Likert scale that was used to assess whether they were satisfied with the performance, and that's what was reported on the slide that I included. We can provide more. We are providing more details in the paper, and you can follow up with a link to that paper. In terms of the magnitudes, what we've shown here actually on this figure are not the relative ones, but rather the absolute effect sizes in percentage points. So when you look at, for example, stunting, it's a 4 percentage point change in stunting prevalence. So it's not a relative effect size. To figure out the relative effects, we'd have to look at what the baseline, what the control group prevalence is. So compared to the control, how much of a reduction are we seeing? And it's certainly a suggestion we can take into account as we revise this. We did not collect costs of the intervention here. I know the World Bank, because this is a project in partnership with the state government, has some of this data, and there have been some discussions to look at those cost information. For our study specifically, we're not looking at cost effectiveness as an objective. In terms of plans before the plans for scale up, there was a question about whether this is indeed an accountability intervention, and you know, it could be that I'm not understanding the question fully, but we do think it's about accountability in the sense that the goal of these community meetings, and I didn't say as much about what those meetings were like, but the idea was to for community members to air their grievances about what was and was not working well in their favor, or what outcomes they were not satisfied with, and for the BHSNC members to be responsive to those comments. So having attended some of these meetings, and also from the reports that we've seen from what these meetings are like, there certainly is accountability at work, in at least the elements of accountability, which is that community members are, number one, informed about what they should be getting and receiving, and also they are having this opportunity to interact with healthcare providers who may feel accountable. The one area where accountability might fall short is at some level, it does depend on whether people above, government officials above the village level, are being informed about what's not working, and can they actually take corrective measures. And that's where we think there's a lot of heterogeneity across villages and districts. As far as the plan for scale up, the social accountability intervention was scaled up across 12 districts as part of the UPHSSP project. There are, I believe at the moment, ongoing discussions on whether this is going to continue to happen in years ahead. That's going to depend on both the funding that's available for this, among other things. But the intervention that we evaluated was certainly part and parcel of a larger implementation across 12 districts.
Okay, thank you very much, Harsha, for those responses. And for Courtney, there's a lot of interest that you should share the study working paper that you mentioned that you can be able to share. So please do share that. And then the same question that was also asked to Angela, like if RCTs is not the answer, then what kind of studies will be the answer? And still a follow-up on that. Would there be skepticism if RCT are the gold standard, and then we start kind of intimating that these cannot be measured that way? Will there be a gold standard for social accountability? Over to you, Courtney.
Yes, those are great questions, and I realize we're at time, so I'll try to answer very quickly. I think one of the most exciting things about the time that we're in right now for monitoring, evaluation, and learning is that there are so many fantastic methods and resources available where RCTs should be part of that package. I absolutely would not say that we should not do RCTs for any accountability efforts. I know of some programs that actually would be highly amenable to RCTs. But I think there's so many other resources that can be used. And I think that there's so many people out there, including those on the line, Jonathan Fox, others, who are really just taking a very smart approach to how do we, in a holistic way, answer the questions that we have about accountability, when accountability is not something that's very cookie cutter. It's not something we're just going to be able to do the same exact thing in 100 different communities. So, I mean, I think things like outcome mapping and outcome harvesting can be incredibly valuable. I do think the ethnographic approach is one that we learned a lot about, especially in terms of the really complex relationship that citizens have with the history of development projects and how that may play a role in accountability and power dynamics. I do think process evaluations are really, really valuable. And while they may not be the things that will, tell you at the end of the day, this 100% was the one causal reason that we saw an improvement in health outcomes, they can tell you a lot about where accountability can break down or how far along the chain it seems to be going. So this is, a plug for the organizers. This would be a great topic just as a standalone for a future webinar. But I do think there's a lot of great resources out there. RCTs should be part of the arsenal, but they shouldn't be the only thing.
Thank you very much, Courtney, and I would really like to appreciate our three presenters. Excellent job. Thanks, Nandita and the IBP for organizing this webinar, and to Petrus, Joanna, and Vicky, who are working behind the scenes on the social accountability community of practice. And just to close, to remind everyone that the webinar recording will be available, and we will send the presentation to all participants, and you can also get them as the handout. And for more information, please visit our website that is listed there. And thank you, everyone, particularly just noting that so many of you stayed despite us going over time. And do have a good day, good evening, or good night, wherever you may be. And bye-bye.
Thank you.
Thank you and bye.